Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm real pleased this afternoon to be talking with Dr. Jen Devoe, who is Professor and Chair of the Oregon Health Sciences University Department of Family Medicine. She's going to be talking about what I think is an incredibly powerful program that documents the value of primary care at a community level. Dr. Devoe, thank you for joining with us.
Thank you for having me, Larry. I'm really excited to be here and excited to share our experiences in building a community laboratory. And I'd like to present this session about building community laboratories and give you some examples from the OCHIN Community Health Information Network, where I serve as a senior research advisor. So today, our overarching goals are for me to first describe the important role played by our community-based networks. They're real-world community laboratories. And then again, what is this? What's an example of one? Well, OCHIN is a great example of a community laboratory thriving. And last, I'll just discuss the potential impact of aggregating data from primary care settings and elsewhere, and then sharing this data to improve population health, patient care, and work together in communities. So really, why do we need community laboratories? Why do we need to move science out into the communities? I think the original Ecology of Medical Care study done by Carr White in the 60s and then repeated by Larry Green and folks at the Graham Center in the late 90s really is a great demonstration of why we need to be out in the community. And this was looking at among 1,000 people in the U.S. during a given month, what is the ecology of their medical care? So out of those 1,000 people, about 800 report a symptom, and just over 300 consider seeking medical care. And of those who do seek medical care, 217 visit a physician's office, and over half of those visits are in a primary care physician's office. And then as you see here, only about 21 go to a hospital outpatient clinic, only 8 are hospitalized, and less than 1 out of 1,000 are hospitalized in an academic medical center. Yet the majority of our teaching and research happens in that small box. And so when we move science and education out in the community, we're really getting out to where the majority of folks receive their care. And now the example of OCHIN. So OCHIN is a very unique organization, a nonprofit healthcare innovation center designed to provide knowledge solutions that promote quality, affordable healthcare to all. A nonprofit organization that's really working to be innovative in collecting data and information from primary care settings and then serving those folks with that information, helping us to improve care for communities. Here's a very quick timeline about OCHIN. OCHIN was founded in 2000. It was founded, and the first work that OCHIN did was to bring an electronic health record, the EPIC EHR, into community organizations. Went live with that in 2005. Very quickly then established a practice-based research network, has become Oregon's Regional Extension Center for Health Information Technology, and then continue to innovate in very great ways to bring the electronic health record and now additional data and aggregation systems to communities, partnering with primary care, and doing some really amazing research with the data and the information systems that OCHIN now has. So I was brought in 2010 to continue to develop the practice-based research network. And we were then able to receive funding from the Patient-Centered Outcomes Research Institute, being the first in Oregon to receive a PCORI grant, then developed a PCORI-funded clinical data research network, and have been working now very actively in primary care, public health, community health settings, and most recently working to develop a conceptual model for integrating social determinants of health into primary care and using the data and the laboratory that we have to learn more about how to do that best. Here's another map just to show where OCHIN is. So OCHIN has now 94 health systems with over 400 clinic sites on the EPIC record, and you'll see that are those light green dots. And again, OCHIN does much more than just provide EPIC to the members. We have billing services included, a broadband network, now a data aggregation system called ACA Quality of Life, or ACA QOL, which is in 23 states, and our research partnerships across the country, represented here with the dark green dots. The OCHIN Practice-Based Research Network, as I mentioned, I like to think about this as building on the amazing 20th century PBRN tradition, but building a 21st century PBRN. Because we were working with OCHIN and through their data and information systems, we have a linked electronic health record across the sites in our PBRN with one master patient index. So that means that when a patient walks into any community health center or primary care health center serviced by OCHIN, their record will be pulled up on that electronic health record, one record. So if I go to an OCHIN clinic in Oregon and I'm a patient there, and then I travel to California, they can see my record in California. If I go to one of our sites in North Carolina, same record. So it's very valuable for care, so that across these 400 sites with over 4,500 providers, we're all seeing the same record, we're all documenting in the same record, coordinating that care. And for research purposes, it is very vital to also have that information all in this one record. For over 1.7 million patients that are actively being seen in these centers, and well over 20 million visits. Here's another map, again, where our practice-based research network sites are. Slightly more than half of our patients are female. We have about 30% racial ethnic minorities, nearly 20% speaking Spanish as a primary language. Many of the patients, nearly 50%, live in poverty, below the federal poverty level. A number of them are still uninsured, although more of our folks in states that have Medicaid expansion are now federally insured, the predominant payer being Medicaid programs, some also on Medicare. So here's some examples of some of the questions that we've been able to ask with our data and information. We have over 20 ongoing studies now, and so this is just giving you a few examples. Certainly you can visit the OCHIN website or contact folks at OCHIN if you want additional details about the breadth of the work we're doing. So here's one question that we asked back when folks were expanding the Medicaid program in Oregon. What do we know about how health insurance affects utilization of primary care services? So historically, when we look at health services research and we try to understand services utilization, researchers have been using insurance claims data. The problem with insurance claims data is we only have that data for people who are insured. So what OCHIN has provided is a significant laboratory and a significant amount of data on those invisible patients that are uninsured and that we cannot find in claims data sources. So one of the things that we were able to determine after Oregon expanded our Medicaid program in 2008 was that utilization of primary care services significantly increased among patients who gained insurance coverage. The other thing that was really helpful within the OCHIN data set was that we had a large number of patients, and you'll see them represented in the dark blue line down at the bottom, that were continuously uninsured. So during this 3-year study, there was a group of patients who were uninsured the entire time. And you can see that that group had somewhere between probably 60 to 65 primary care office visits per 1,000 patients. There was also a group that you can see represented in the gray line that had somewhere between 150 upwards to 175 primary care visits per 1,000 patients. That's the group that was continuously insured. So that group had coverage for 3 years. And then the group that had the change in coverage represented in the green line and the yellow line, those were the folks who had been previously uninsured, and they had the utilization very similar to that continuously uninsured group. When they gained coverage, you can see their primary care utilization increased significantly. What some folks weren't able to do was follow those patients out beyond the 6 months of coverage that they gained to see that actually more than half of them lost coverage, and that group's utilization dropped down. Those that gained coverage and maintained coverage had utilization looking much more like the continuously insured. So this type of community laboratory is very powerful in studying what happens when policies change, when practices change, to get a sense of how utilization changes during those natural experiments. So we're embarking on studying the larger natural experiment. We had the Oregon expansions in 2008. Now we have the expansions after the Affordable Care Act, where some states are choosing to expand their Medicaid programs and some states are not. Of course, with our national network, we are serving states that expanded and states that did not. So we were eager to look at what's happening in utilization among those different states and among those different patient populations. So we did a very initial pilot study and are now continuing some longitudinal studies for the next 3 to 5 years. But this is really just reporting on our first study of patients in 5 expansion states and 4 non-expansion states and how their utilization differed. So comparing those in expansion states in blue and those in non-expansion states in orange, we can see that over time there was an increase in total visits slightly among those in expansion states and no difference in non-expansion states. The difference in uninsured visits is very clear here, that in the expansion states, their uninsured visit rate dropped precipitously. There was also a drop in the non-expansion, and then conversely, the Medicaid visit rates jumped up quite substantially in the expansion states, and just a small amount in the non-expansion states. Very little change with those that were privately covered. We have a small percentage of our patients with private coverage. More here in really highlighting that expansion states saw a big increase in new patient visits and preventive visits, limited service visits as well, and those would be visits that were not seeing a clinician, but that were coming in for a nurse visit to receive lab services or immunization, or perhaps some other services that the patient perhaps wasn't able to access when they were uninsured. The highlights, again, as I mentioned, we saw several significant pre-post visit-based changes in the expansion states, with a 47% decrease in uninsured visits, 46% increase in Medicaid visits, 41% increase preventive care, 23% increase in limited service, and 14% increase in new patients. There were some changes among the non-expansion states, fewer and more muted, in that they saw a small decrease in their uninsured visits and a slight uptick in the Medicaid insured visits. And some of this can be explained by some of those patients gaining coverage through the exchanges, and that some patients who perhaps qualified for Medicaid under the traditional rules in that state were just more aware of Medicaid and were able to sign on, despite the fact that the state isn't expanding their program significantly. So a 21st century PBRN, or a community laboratory. A lot of people, when I talk about this, say, well, who has time for research in today's clinical settings? We are spending all of our time entering data into our computer. And some of you might believe that you have a clinical integration engine that looks a bit like this octopus that's wheeling through the halls of this clinic here in this cartoon. So it's true, we're spending a lot of time entering data, working with EHRs, figuring out how to make them work more effectively for us. But wait a minute, did you just say data? So that's something that's very powerful. If we can aggregate this data, we're all scientists, we have science at our fingertips, we're entering and collecting data daily, by the minute. This data has the power to improve our practices and our population's health. We all work in community laboratories. So there's a small video here that we're going to play, which is an example of my teaching our academic institution about primary care community laboratories. So about a year ago, I was inducted into the National Academy of Medicine, or what was formerly called the Institute of Medicine. So my election into the IOM, or the NAM, was a surprise for folks here at OHSU. And they wanted to highlight my scientific work. And so they said to me, we want to come and take pictures of you and do a video about you and your work in your laboratory. And I kind of thought, well, my laboratory. And then I realized, well, it's my clinic. Come on over and I'll give you a tour. And you can see the kind of innovative work that we are doing in our community laboratories. So we in family medicine and primary care and community health, we all work in community laboratories. So let's go ahead and play this video, and you'll get a sense of what we were able to show our institution.
but not the Montana other girl. And then I went to Boston and went to Harvard Medical School, moved to England, went to Oxford for off and on 4 years, went back, finished my medical degree, traveled around the world to study different healthcare systems. And then I came to OHSU for residency and did additional studies here to become a better researcher. Every day physicians see patients struggling to gain access to basic care, medication, information, a hospital service that many of us would take for granted. So we need to start thinking about other ways to intervene as advocates to change policies, as innovators to change our practices to become more patient and family-centered, and then as well as partners with our patients and our teams one-on-one, identifying individual needs and then helping to meet those needs. My election to the Institute of Medicine was a great surprise and a huge honor, largely due to the fact that I'm trying to do things a little differently than some folks have traditionally done in biomedical research. Moving towards teams, we're using data from our electronic health records to identify patients that may be at risk. Assistance with care management, we have care managers working with that data. You need a team to take care of a patient. You need a team to do a research study. You need a team to think about how to translate what you're finding and disseminate that information to many different audiences. And so nobody can do this alone.
Great. Thank you very much. We can end the video now and move on to the next slide.
Let me see if I can stop things here and get back to our main screen. And I'm turning control back to you.
Great.
Okay.
Great. Thank you. So one of the things that we envisioned and that we're very excited has been happening in OCHIN's community laboratory is hitting a sweet spot between practice transformation and research. And that's really where the community laboratory thrives. It's a laboratory that's providing the resources, the expertise, the innovation to support practice transformation work like quality improvement, the workflow redesign, the health information technology support and development, all of these exciting things that we're doing within patient-centered medical homes and enhanced primary care. At the same time, the same infrastructure and the same resources are supporting research. We have an electronic health records data warehouse. We're building registries. We have the infrastructure, the methodologists, the expertise to do the kind of research and science to inform practice, inform policy, and widely disseminate the findings from this science. So the community laboratory has really helped us find the sweet spot and expand it. As you can see, the more that these circles overlap, the greater benefit we have from the laboratory and the resources that we've developed, and the more likely it will be sustained and it will continue to grow. So one of the ways that we're really bringing the research and the practice transformation together and thinking creatively about data is through the ACA network. This is a software product that OCHIN's developing and that our researchers are contributing to bring data together to improve patient care and make sure that this data is available to all of us. Again, bring science to the point of care so that we are continuing to innovate and use this information to improve care. So the data is now on the ground in the real world in real time or near real time. It's not waiting 6 months to understand what's happening. It's waiting less than 24 hours. So this is a near real-time data aggregation that's facilitating evidence-based care, quality improvement, population health analytics, and incorporating multiple sources of data. So it's not the traditional claims data, as I mentioned. It's clinical data from the electronic health record. It's claims data, a community data, creating a warehouse analytics and a healthcare intelligence system, and then providing interactive tools that have different display layers so that you can combine these data sources and look at your clinical data and your financial data and your administrative data in order to review the details of the care that's being delivered over time. These are a couple of snapshots of the ACA system, which is very interactive in real time. Point and click enables you to identify populations of patients, identify providers, identify metrics, and then look at them over time and compare them provider to provider, clinic to clinic, across the network, and over time. A couple of other examples here. Many different dashboards have been created looking at some of the traditional metrics related to clinical care quality, finances, and operations. There's also a feature that enables us to pull up patient rosters, so a clinician can look at, I want to look at all of my patients with diabetes, and I want to get a sense of where these red zones are, where they may be, their blood pressure may be out of control, or they need an A1C, or their A1C is out of control, or they're not on a particular medication that's indicated based on evidence. So really enables to slice and dice the data in very innovative, useful ways. Also the scrub list, so that you can look at the information for patients coming in next week, tomorrow, today, and have the team be better prepared for that very, very precious face-to-face time, and to have those population managers and care managers looking at this data outside of visits and understand, let me look at my list of patients and scrub that list and figure out who really does need to come in for a visit with the physician, or who can I call and help with some of these needs over the phone, or who can I send an email, et cetera. So one of the other terms that we've coined that we really love is the patient-centered medical village. And this is a way that we're sharing this data and information across multiple patient-centered medical homes, PCMHs, also thinking about Medicaid organizations, public health departments, federal and state offices, bringing data together into this patient-centered medical village, an innovation network for sharing the IT support, the data sharing, a flow of knowledge. Not every individual PCMH needs to recreate the wheel, have their own IT department, have their own quality improvement coaches, have their own data system. This can be shared. So a network of patient-centered medical homes can share IT, data resources, and best practices. And then we can begin to develop village champions that are helping to spread the innovation. So here's an example of one of the early studies that we conducted in this patient-centered medical village. We looked at data quality, and we said, gosh, across 23 clinics, and that was in the early days when OCHIN was much smaller, we wanted to get a sense of how well we were doing with some of the traditional quality metrics related to what we should be doing for diabetics. So how many of them had had an LDL checked? How many of them had had a flu shot? How many had had a microalbumin or a hemoglobin A1C screening test? And you'll see here, even across these 23 clinics who have somewhat similar patient populations, there was wide variability in the percent of patients who had received these services. In a few clinics, it was less than 20%. In other clinics, it was close to 100%, and everywhere in between. So this data and the patient-centered medical village enables us to just get a sense of where are we at and how much variability do we see. The other thing that's really exciting is once we have a sense of where we can improve, we can begin to study interventions using a cluster randomized trial design. So rather than randomizing at the patient level and recruiting individual patients into a study, we recruit at the clinic level. And we say, okay, great, you know, in this study, which was our first clinic randomized control trial, we were working on getting diabetics who were indicated for lipid-lowering medications, primarily statins, and patients with diabetes who were indicated for an ACE inhibitor or an angiotensin receptor blocker. And we wanted to get a sense of what percentage of patients are on these two important medications, cardioprotective medications. So we said, we've got 12 clinics, we're going to randomize 6 of them to get an intervention early. And so you'll see here the early intervention was implemented in June of this year, and the early clinics are the intervention clinics. The late clinics in red are the control clinics. So for that first year from June to June, there was a significant increase among the intervention clinics, those who got the intervention early, in the percent of patients appropriately prescribed these indicated medications. Then when the intervention was implemented in June of that second year at the late clinics, you'll see them catching up. So this is a nice way to have a control for any quality improvement intervention or other transformation initiative that you want to implement at the clinic level. It's a way to have a control clinic to understand that, well, gosh, yes, it probably was this intervention that created this change, and it wasn't something just going on in the background, and that not all clinics were improving their care in this way. So it's very exciting to have community laboratories to do these kinds of scientific experiments. So the other thing I did want to mention is I do want to be very humble, and it is humbling when we look at the World Health Organization conceptual model about what has an impact on equity and health and well-being. And so we're talking about doing really cool things within that tiny little box there at the bottom in the rectangle where it says health system. So again, humbling to realize that we are doing cool things with clinical data and claims data and looking at healthcare utilization and looking at how we can transform healthcare. And we are making transformative changes. We are amidst this larger group of factors that are really contributing to equity in health and well-being. So humbling, I want to continue doing this work in the clinical setting. I think we do, though, need to think beyond that. And so I want to give an example of where OCHIN is going with the clinical data research network that we're building, which we call Advance. This has multiple partners: OCHIN, Health Choice Network, Fenway Health, the folks at the American Academy of Family Physicians Robert Graham Center and Health Landscape, Care Oregon, which is our largest Medicaid managed care organization and coordinated care organization in a number of regions in Oregon, Kaiser Permanente Center for Health Research, Legacy Health, one of our hospital systems, and Oregon Health and Science University. And what we've been thinking about with Advance, and this is really starting, again, to aggregate more sources of data. We have the clinical data from OCHIN, Health Choice Network, Fenway, and much of that is ambulatory from the outpatient setting, but we're able, through the claims and some of the hospital data, to better understand utilization across the spectrum of ambulatory, ED, emergency department, and inpatient hospitalization. Also asking patients for information, incorporating the patient-reported outcomes into the electronic health record and then into this data source. And then down at the bottom there on that left-hand side, it's very important that we start to include information about social determinants of health. So we're working very hard to, at the community level, identify all the information that's already known about the neighborhoods and the communities where our patients live. And this is where they're working and playing and residing, and this is all very, very impactful on their health. So how can we capture some of that community data, the community vital signs, and then bring that together with some of this more traditional health data and the health vital signs clinical data? We're putting that all together in our advanced research data warehouse with a common data model for much of the clinical data, but an expanded data warehouse with the community vital signs and additional data relevant to our population. And that is then becoming part of this larger PCORnet, the network that Patient-Centered Outcomes Research Institute has supported and is continuing to build. So how can this aggregated clinical data and this community level data help, for instance, patients gain insurance? This was one of the questions that we had related to the insurance study that we had done. This is one example of many, many, many more where we can bring this data together in innovative ways. So we demonstrated that we could build geospatial tools aggregating what we knew at the clinical level, and in this sense it was really about insurance status, but you could aggregate data about diabetes diagnosis or obesity and body mass index levels or blood pressure or anything that you can think of, aggregating that data with community data. And this really then was available to our clinics, primary care network, as well as community partners to help the community health centers partner with communities to help get more children covered by insurance. So looking at bringing that data out of the electronic health record into the community. So we knew from every single one of these kids who had presented to the clinic uninsured. And then we can begin to map that information so we know where the uninsured children are clustering so that we can partner with specific community organizations there. We also were able to layer in income data. So we knew, wow, this neighborhood where the majority of our uninsured kids are from also has very low median household income. So it's likely that almost all of those kids qualify for a public insurance program. So how can we then go to those specific areas and do outreach to those populations? I mentioned the community vital signs. I think that bringing that information into the electronic health record could improve care and health. And so we're thinking about how do we bring that information in in a meaningful, actionable way so that clinicians and teams that are working with populations and patients can better understand what the community context, better understand information about the community context in which they live. There's a lot happening with the National Committee on Vital Health Statistics in developing a vision for how this clinical big data can be shared with communities to support population health. The concept of the community as a learning system is being developed. So how can we utilize our electronic health record data, clinical data, to improve our practices, but then how can we share that information through this larger community learning health system? And you'll see down at the bottom, academic foundation and community data partners I have underlined. So again, very humbling to think about, wow, we have an amazing amount of data, and we are just one of multiple other organizations that also have very valuable data. And so if we contribute our data into this community-focused initiative in order to exchange that information, it can really help to improve the community's health and the population's health. Recently, we talked about, or we wrote a paper in Academic Medicine, and this is out ahead of the print, so it's only available online. The link is down below, but it will be coming out in print in Academic Medicine soon, and really pulling together the fact that we need these kinds of community laboratories to support the science of health. Traditionally, in the 20th century, academic medical centers have done a phenomenal job in building laboratories supporting the science of disease, combating disease, and we're arguing that we also need complementary laboratories that are supporting the science of health and building on the infrastructure from public health that is already in existence and bridging that across to the academic medical center, the medical school, and the primary care department. And then another interesting model that we put together that's part of that publication is that we need more community academic partnerships to support population health. So where do these community laboratories fit within this model? Well, they really fit alongside many of the scientific centers of excellence that can be built in multidisciplinary and transdisciplinary ways. So we have scientists in dissemination and implementation science, health services research, patient-centered outcomes research, and those scientists, whether they be academic scientists, patient investigators, clinician investigators, can then have these real-world laboratories and also the real-world classrooms for educators in order to innovate and disseminate the information. Of course, there's the core resources that we talked about with the patient-centered medical village, and that's the centralized data, measurement, analytics, also a centralized function of engagement, patient engagement, community engagement, engaging with folks out in the real world and practicing in some of our health systems that aren't necessarily affiliated with the academic health center. And then the core functions of the education and career development. So we talk about, in 2020, which is not very far away, what have we accomplished if we continue to move in this innovative way? Well, we'd like to say that we've accelerated primary care transformation, innovation, and discovery through the innovative community academic partnerships we've outlined and we've begun to demonstrate. We've partnered to develop big data, aggregation systems, methods, and useful data sets to support communities as learning systems and to inform and measure population health improvements. And we've strengthened the infrastructure of community laboratories and classrooms that innovate, evaluate continuously, and train future generations. So we are going to continue doing this work. We'll hope that you'll be inspired and continue doing this in your communities as well. We'd like to acknowledge several funders who contributed to the projects that I highlighted and demonstrated here, and they're listed on this slide, including the Agency for Healthcare Research and Quality, National Library of Medicine, National Heart, Lung, and Blood Institute, National Cancer Institute, Health Resources and Services Administration, and Patient-Centered Outcomes Research Institute. Also, OCHIN is very supportive of this work, as is the OHSU Department of Family Medicine and several other academic departments that are now working with the OCHIN laboratory and partnering on research studies. And huge thanks to all of the clinics and patients who contributed to the research. Thank you very much. I really appreciate the opportunity to speak to you. Again, as I mentioned, you can Google OCHIN, O-C-H-I-N, or go to ochin.com and find out lots of information, ask your questions, send us additional questions or ideas, and would love to continue the conversation. Thank you very much.
Dr. Devoe, thank you very much. I did have a couple questions for you. Number one, where do you see this going? What are the big next steps that you see over the next few years?
So I think a really big step, again, ties in with the big data and thinking about using some of the methods that are used in other big data sources. So I'm thinking that a lot's happening in the genome data, genetic data. We have big data in community health as well. And so how can we bring our data together in these very innovative ways and then use some of the big data methodologies to help transform care and improve the work that we do every day? So I think there's a lot on the horizon around big data initiatives and the development of methodologies for aggregating and studying and utilizing that information, and then bringing it to us and our patients and our communities at the point of care. One of the projects that's been very, very exciting is through the American Board of Family Medicine, led by Dr. Bob Phillips, in building their registry. So imagine if we had data from every single family physician and family medicine clinic across the country that was protected, secured, used in very appropriate ways, and was all aggregated in such a way that we could better understand the care that we provide and improve what we're doing nationally, sharing those lessons with each other. So I think that's where the American Board of Family Medicine is looking and has a great vision with their PRIME registry. Again, as I mentioned, OCHIN, building on the shared IT and data, and then thinking about how do we use that information. So practice coaching, practice facilitators, how do we help folks around the country bring the data together and then use it in actionable, useful ways is also something that folks are figuring out how to do across the country and will be really helpful for us as a discipline in moving everything forward.
Great. And you mentioned that most of the participating organizations in OCHIN are community health centers. Can independent practices or can hospital-owned practices join the OCHIN network? Do they have to be using an EPIC platform?
One of the really exciting things about OCHIN is now there are a number of ways to join the network. So we have our EPIC members who are on the EPIC electronic health record that's hosted by OCHIN, and it has the master patient index and has been the core to the business. Now there are members joining the ACA. So you can have any kind of electronic health record, any type of data in IT, and bring your data together through the ACA data aggregation. And we showed those screenshots of the dashboards that OCHIN has developed and much of the benchmarking that's available. So all of the EPIC members are in the ACA network now, and that is including many, many other practices that do not have EPIC or are not part of OCHIN's EPIC network. So yes, it's possible to join OCHIN and become part of OCHIN's network and be very actively engaged in research and data with a different EHR platform through the ACA opportunities that are now available.
Well, that's very exciting. Are there costs to joining the network?
So ACA has a cost associated with it. It is a service that OCHIN provides for folks to gain access to using that. So the same way that people pay for an electronic health record, this is an additional software that enables you to aggregate data in this way. So there's prices associated with what services you would need and how you would be using that data.
So within a given community, let's say we took Dayton, Ohio, where I am, if there were a number of practices, would you see the potential for really having an improvement in the health of the population of Dayton?
Well, it's really exciting because Ohio has a lot of similar projects already in flight. I know certainly about some in Cleveland. I know there's some in Cincinnati where Andrew Bazemore was working on faculty and helped develop the health landscape product that's partnering with us on the geospatial analytical work. So there's a lot already happening there. And then certainly there's clinics that are as part of OCHIN's EPIC network in Ohio too. So yeah, I think that we're at the tipping point in a lot of these communities of having this data infrastructure developing and develop to a point where it is going to be improving community health, especially if we can get to the point of realizing the vision of the community as a learning system and it being more than just the healthcare system, but moving outside of the traditional healthcare clinic and hospital walls out into the community and partnering very effectively with many other community organizations.
So you would think that any organization that was hoping to be an effective accountable care organization, they might find this platform extremely helpful instead of developing their own standalone product.
Yes, exactly. I would say for sure. The way that it really helps to aggregate information at the population level is very transformative and certainly a vital resource for any accountable care organization to have this type of data infrastructure. And again, I think it gets back to that sweet spot where we really do need to have this data and infrastructure available for delivering care and identifying populations at risk and continuing to do research and supporting practice transformation.
That's very exciting. And the other thought that I had as you were presenting is having heard some of the conversations early on as family medicine began back in the 70s and the 80s, there was a great hope that there would be a research and scholarship that drove family medicine. And I think the founders who were voicing that concern would actually be drooling right now to see how far this has come. When I think of the Virginia study, which was one of the early community-wide projects, and how limited the impact of that was, although it was groundbreaking at the time, you've come such a long way. It's really impressive to see the work that you've done.
Thank you very much.
So I think we should finish now. Thank you very much, Dr. Devoe. It's been a pleasure talking with you this afternoon.
Thank you for having me.